Thank you so much. Thanks to the Karolinska Institutet for asking me to have this lecture, and thank you for joining during your lunchtime to spend 30 plus minutes with me. I'm happy to stay and discuss and answer some if you have any questions after my talk. All right? So first, some words I couldn't resist just to speak a little bit about myself. I'm a little bit older than 60 years of age. I graduated from this very school 1983 as an MD, and I became a specialist in surgery 1991. Now, it's not very common that surgeons that are specialists in surgery step off surgery and do research for 4 years in a lab, but that's what happened to me. So I defended my PhD in 1995, and I did a postdoc, and I came back and I became a docent in 1999, and last year I became professor of endocrine surgery, or surgery with a specific aim of endocrine surgery, and I will tell you more about that. So this is what happened to me when I was a resident in surgery. I was 35 years of age, and I was aiming to become a skilled surgeon, a great clinician, and nothing else. And I came to the Karolinska hospital to do my last year of residency, because everyone had to do such a year in a big hospital. But my intention was to go back to rural hospital and become a skilled clinical surgeon. Then I met this professor, Bertel Hamburger, an academic surgeon and a professor of surgery. And the first question he asked me, well, do you want to become an ordinary surgeon or do you want to become an academic surgeon? And the answer was not that easy for me because, as I told you, my aim was to go back. But it ended up with a project in endocrine surgery in thyroid tumors. That's how I ended up. And then I got an offer I couldn't refuse. I couldn't resist, from the Godfather. That was to spend 4 years in a genetics lab. That was unheard of for a surgeon. I didn't know what an Exxon was. I thought Exxon was an American fuel company. And when I asked people where the cDNA library was, people looked at me as if I came from another planet. But nevertheless, I spent my 4 years pipetting and doing molecular research. And now I've ended up as a proud research group leader of endocrine surgery with a flower like this, with many different research subgroups from many organ systems and many endocrine disorders. But today I'm going to talk about thyroid tumors and thyroid cancer. This is the most common endocrine malignancy, and it is increasing. In Sweden, we see 600 new cases every year, which is roughly 1% of all new cancers in Sweden every year, 1%. But it is increasing very rapidly, especially in the United States and other Western countries like Australia and others. And people don't actually know the exact reason for this. Part of it is because we look much more thoroughly with radiology, with ultrasound and so forth. But it cannot be the only explanation, because not only small indolent tumors are found, but also more advanced stages. So there is an increasing incidence. It's an enormously variable clinical course in thyroid cancers. And I will come back to that. And that's why, that's one reason why this is such an interesting entity to work with. The thyroid is made from follicular cells that make the thyroid hormones. And from these cells, the follicular cell-derived cancers arise. The most common being the papillary thyroid carcinoma, roughly 80% of all thyroid cancers. There is also follicular carcinoma, which is not as common as the PTC. And then we have the much more uncommon poorly differentiated carcinoma and the dreadful anaplastic carcinoma, and I will come back to that as well. Something I won't talk about, although I've spent a lot of years doing research on this entity, is the medullary thyroid carcinoma, which emanates from the perifollicular C cells that make calcitonin and not thyroid hormone. Right? So I will mainly speak about these follicular cell-derived cancers. Some facts about thyroid tumors. 5% of all people have a palpable nodule in the thyroid. So if I investigate every one and each of you, I will find some with a nodule in the neck. And that's not to worry about. That's just a fact. If you use an ultrasound probe, you will find changes in roughly half of the population. And as physicians around the world, they get $200 extra if they do an ultrasound of the neck if someone complains of a lump in the neck. Although you cannot palpate, you do an ultrasound and you find a little nodule, then that might be a thyroid cancer actually. Fine needle cytology, aspiration. You suck out cells with a fine needle, you spread it out as butter on a sandwich, and you look in the microscope after having stained the cells. That's the hallmark of diagnostics in thyroid tumors, as in many other tumors. Do you know which hospital, at which hospital fine needle cytology was invented? Right across the street. At the end of the 1940s, actually, it was invented firstly for prostate, but shortly thereafter for breast and thyroid tumors. So it was an explosion at that time. Very few of these nodules are malignant, luckily, but some are, and we have to find out which that are malignant. There is a specific entity called follicular thyroid tumors, and most of these are benign, but we cannot tell before we operate the thyroid. So 10 or 15% are malignant, and we have to remove at least half of the thyroid to be able to tell whether this is a malignant tumor or not. So we make an unnecessary operation in maybe 85% of these patients. Papillary thyroid carcinoma, that's very common to find, very small papillary thyroid carcinomas. 10% of you have a papillary thyroid carcinoma. And we know this from autopsy studies, for instance. So if we do investigate all thyroids with ultrasound, we will find a lot of papillary thyroid cancers. But they are indolent. People will die with them, not from them. So they are passengers only. So don't go and investigate your neck unless you have a good reason to do so. Now, papillary thyroid cancers, they have an excellent prognosis, provided that the patient is young, but also if the cancer is spread, the prognosis is still excellent, and that's quite uncommon. If we have a 25-year-old female with 25 lymph node metastases, and I can still say to this 25-year-old lady, we will cure you. The prognosis is excellent. You will live as long as if you did not have this cancer, provided that you get the right treatment, of course. There are exceptions, as always in life, there are exceptions. The follicular thyroid carcinoma, also excellent prognosis, but not as great as the papillary. And then we have the anaplastic. Luckily, most patients that get an anaplastic thyroid carcinoma are elderly. The youngest I've seen was 48 years of age. But extremely few patients survive 3 to 6 months from diagnosis, which is worse than pancreatic cancer, worse than lung cancer. It's one of the only cancers you can see grow from Monday morning rounds to Monday evening rounds. I've seen tumors grow during daytime. It's dreadful. And the patients, if they don't get the palliative treatment, they're strangled to death during 3 to 4 months. And seeing patients suffer from this, you don't want to experience that more than once. Okay, some words about thyroid tumors, the treatment. If you have a benign tumor and the patient have discomfort from this, you can remove it by taking half the thyroid away. And you remember I mentioned the follicular thyroid tumor. You take half of it away. If it's not malignant, then you can leave the patient and say goodbye. You don't have to come back. Thyroid carcinomas, however, are usually treated by total thyroidectomy. That is, you remove the entire thyroid, which is in the neck. You also often remove lymph node glands, especially if they are, of course, visible and if you have tested them to be metastatic. After the operation, you provide the patient with radioactive iodine to ablate the normal remnants of the thyroid, but also to find out whether the cancer is spread and to kill the last of the cancer cells. You give thyroxine suppression, that is, the patient eats T4 or thyroxine to keep TSH low. TSH from the pituitary is a growth factor for these cells. So you want to keep that low. If you have a spread disease which is not otherwise treatable, there are new novel tyrosine kinase inhibitors that are in use. And sometimes there are dramatic positive effects, actually. Now, the anaplastic thyroid carcinoma, that dreadful tumor, the patient is immediately taken into the hospital to get external, very heavy hyperfractionated radiation, external, and then cytostatic drugs, and then we operate the patient for palliative reasons because we don't cure them, but we want to save them from 2 or 3 months of slowly getting strangled. They die from lung metastasis or something like that, but not from this local growth into the vessels, into the windpipe and so forth. Dreadful. Okay, these have been our main research questions since many decades. How can we identify the thyroid cancer that will recur and eventually kill the patient, despite that they look superficially quite the same? If you look in the microscope and you look at the patient, some patients, they recur very often, and sometimes they don't. So we want to distinguish what is the difference between these tumors. Which patients should be offered more extensive treatment of various sorts? Can we offer them better follow-up? Can we tailor the treatment to the patient? And can we preoperatively, before we have taken out the tumor, distinguish those that are aggressive so we can offer the patient the right treatment to begin with and don't have to come back and do more surgery and more extra operations, because that's not a very nice situation for the patient. Do benign tumors progress to malignant, or can we leave them and be safe with that and say, this is a benign tumor, it won't change. If it doesn't grow, fine. We don't need to do anything. Can we be sure? And on the other hand, do differentiated cancers and tumors, do they undergo dedifferentiations to this anaplastic, which is an undifferentiated carcinoma, to the anaplastic cancers? So there is a need for better diagnostic and prognostic tools, and that's what our research has been focused about, and I would tell you about 2 of these things that we have introduced after having studied them. This is from another group in the United States, and it just illustrates the problem. These are a lot of differentiated thyroid cancer, that is papillary and follicular thyroid cancers. These are years, and we have a scale here up to 40 years, and this is % of recurrence. And as you can see, up to 40% still recur after 4 decades. So the patient is not safe. We cannot say, goodbye, you don't have to come back. But we want, of course, to be able to distinguish these very early on, who we have to look very thoroughly upon. So we have used a marker of proliferation. Ki-67, it has nothing to do with the Karolinska Institute, unfortunately. But it's a nuclear antigen which is detected by a monoclonal antibody, and it's very easy to use. You can even apply it on fine needle aspirates. You remember we suck out a couple of 100 or 1,000 cells, and we can stain and we can count how many of the tumor cells are positive, how many are in proliferative status. It's well validated in many tumors, not least neuroendocrine tumors, for instance. And we can do comparisons. We call it the MIB1 index, that is the percentage of positive cells in hotspots. It's been used in other cancers, and in papillary thyroid cancer, it's usually extremely low, less than 1.5%. That's low. Some lung cancers are above 80%, for instance. Usually it's very high in anaplastic thyroid cancers, but very low in PTC. This is the first study on thyroids that we performed many years ago. And we looked at the MIB1 index, that is positive tumor cells in various thyroid tumors. And we could see there was quite a great spread from 0 up to 12 in papillary thyroid cancers, but very high in anaplastic carcinoma, but also a lot of overlap. So we cannot use it to diagnose those that are dangerous, because some papillaries are much higher than the anaplastic and so forth. So that's not the use we have for this to do diagnostics. But what we could see was that in the papillary thyroid cancers, NED means no evidence of disease, and these are the ones that recurred or had distant metastatic spread. They had a much higher value on this. So, could we use this for prognostic reasons? In this small material, we found that if the value was below 1.85%, the patients did good, and if it was above 1.85%, the patient got recurrence from disease. This is a Kaplan-Meier curve with time on this axis, and in this case, disease numbers with disease-free survival on the y-axis. So we wanted to expand this and look at fine needle cytology specimens to see if we could use it pre-operatively, because the other one was on operated patients. So we continued with the fine needle aspirates, and these are some images showing you that this is very low. It's just one cell of several hundreds. Here it's high, it's 40%. And in this case, an anaplastic thyroid cancer, it's even 60%, which is very, very high. Again, a big overlap in different tumors. FTA is a follicular thyroid adenoma, that's a benign tumor. Follicular thyroid cancers, pretty much the same. Papillary thyroid carcinoma, big spread here. And the anaplastic thyroid carcinomas, up to 100% of the tumors are proliferating. Could we use this now for prognostic reasons? Because, again, not for diagnostics, useless for diagnostics. Here we look at the fine needle values, and if the MIB1 index is below 4%, the patient, this is disease-related mortality. The patients do excellent. If they have above 4%, at least 40% of them have died from their thyroid cancer. And it's the same pattern, but looking at distant metastases. So the conclusion with Ki-67 is that approximately half of those with a higher index, and high is still low, but above 4%, they will die from this disease. And you remember I said it's almost an indolent. It's an excellent prognosis. So the few that we can catch with this, we have to follow extra thoroughly. But we can do that. If you, on the other hand, have a low MIB-1 index, you won't die from your disease. And the beauty with this is that you can look at this pre-operatively on the fine needle aspirates. And other groups have now repeated fairly much the same figures as we have presented. So this is more and more established. It's not yet in the national consensus guidelines, but I think in just a couple of years it will be introduced in the national guidelines for how to treat these patients. We use it now at the Karolinska to judge who we shall follow thoroughly and who we can let go, so to speak. All right, now to something completely different. This is a gene involved in the tyrosine kinase cell signaling pathway, BRAF. And point mutations have been described in BRAF, which is part of this cascade. And in papillary thyroid cancers, it varies in different studies, but a substantial portion of these do have activating point mutations in BRAF. As I told you, still most of these patients do well, so there are contradictory results from this. But if you have a BRAF mutation in your papillary thyroid cancer, there is an increased risk of lymph node metastases and recurrence. Will it kill the patient? Perhaps not. As I said, if you're young, you can have lymph node metastases and still be cured. Should this alter our operative strategy and our follow-up strategy? Well, these are just, this has been studied by others, and there is a significantly increased risk of recurrence and lymph node metastasis, as I told you. And you can also use this. You don't have to sequence the gene as such to find the point mutation. You can actually use a monoclonal antibody now to detect the mutation. So the mutated protein can be detected in specimens. It's possible, therefore, to apply on fine needle aspirates. We can also sequence, of course, DNA from fine needle aspirates, which we do. It's predictive to response to one of these antibodies directed to the tyrosine kinase signaling. This antibody then inhibits the activated BRAF and cuts off the cell signaling. All right. This offers a novel treatment to patients with a tumor with a BRAF mutation that cannot be cured with surgery or some other treatment. Anaplastic thyroid cancers, roughly 20 to 30% of these have a BRAF mutation, probably because they are de-differentiated from the papillary thyroid cancer, which had a BRAF mutation. So it's a de-differentiation process. Does this mean anything? Well, this is a CAT scan over the lungs of an elderly man. They are absolutely full of metastases from an anaplastic thyroid carcinoma. He got this drug, and 6 weeks later he's free of cancer. So first described ever this dramatic effect. But it opens new doors to new treatments. Remember the BRAF now. I will talk shortly about telomeres and telomerase activity. Telomeres and telomerase protect the ends of chromosomes to stabilize them. Telomere repeats is formed by telomerase, and some of you may remember that this was awarded the Nobel Prize in 2009. In normal cells, the telomeres are usually shortened, but in tumor cells, they are maintained for the tumor cells to survive and not undergo apoptosis. An activation of telomerase is therefore found in the majority of cancers, actually. And TERT is a part of the telomerase, and is a reverse transcriptase, part of the telomerase. And in the TERT promoter, not in the translated region, but in the promoter, we can find activating mutations. This was first described in melanoma, but very quickly we looked in thyroid cancers. And it was actually found in a lot of thyroid cancers, and I will come back to that. This point mutation increases the TERT expression as such, and therefore the telomerase activity is increased and the cells escapes normal senescence and so forth. This is what we looked at just a couple of weeks after it was described to be present in malignant melanoma. And we looked at various thyroid tumors. And in half of the anaplastic thyroid cancers, we could find the TERT mutation. And roughly in 1/4 of the other common thyroid cancers. And this was also seen in others following our original report. In the anaplastic thyroid carcinoma, it has no prognostic meaning because, as I said, almost all patients die anyhow. So we cannot use it for prognostic reasons, but maybe as a target of treatment, as I showed you earlier. In follicular thyroid tumors, we saw that a quite big fraction was mutated in the follicular thyroid cancer. And here we could see that the mutated died more often than those with the wild type TERT promoter. These are not great numbers, but we have come back and looked at much bigger materials, and I will show you some of these data within shortly. In papillary thyroid cancers, again, roughly 1/4 of them are mutated, and here we see very nice discrimination between those that die from the disease. They have, to a large extent, a mutation in the TERT promoter, and those that don't, they do well. This also correlated with a higher age, and of course, distant metastasis and shorter telomeres, which is self-evident. Now we've looked at larger material of the follicular thyroid tumors. These are plenty of tumors, and we see now that the same pattern is there. If you have a higher mRNA expression, the patient do worse. If you have some aberration whatsoever in the TERT promoter, the patient do worse. And these are gains of the gene. If you have gain of the gene, the patients do worse. So, just to summarize, the Ki67 is very useful for predicting the prognosis, especially in papillary thyroid cancers. And BRAF and TERT mutations, they are of prognostic interest, but also for predicting response to novel medications. There are novel medications directed towards the TERT and the telomerase activity. Very interesting for these patients, of course. So one should apply these tests to fine needle aspirations done. There are several thousands every year done across the street from patients with thyroid nodules, so we can extend the prognostics, prognostic judgment. We can improve the prognostic judgment and really go for where the gold is. We do this to find those patients that may have recurrence, so we can catch that early and hopefully cure the patient. So, should really surgeons spend time? I would just end up with half a minute of a little bit of philosophy. Should a surgeon really spend time in a molecular lab? Is that worthwhile? Well, I won't become the world's greatest surgeon, and I won't become the world's greatest researcher, but minus times to minus is plus. Don't forget that. And I have to say that the most skilled surgeons that I've met, not only here in Stockholm, but all over the world, they usually also are great researchers. There are exceptions, absolutely, but it goes hand in hand, and we may discuss why. The clinical questions of today, they are often answered by preclinical techniques. So if we have a clinical question, I must know what could answer this question. Where should I go to talk to the guy that has the machine that actually can look for the things I'm interested in? So I need some background and some know-how of where to look. And clinicians and basic researchers, they can cross-fertilize them, each other's. So we can come with our clinical material and the clinical question, and the basic researchers that have ideas on a very basic level may look if this holds true in clinical materials, and that's the aim for everyone in this building, to improve health, isn't it? So by doing this, in my case, I could see the world. I could travel around and talk about these things, and I could see that others did different than myself and other surgeons around the corner, and sometimes they did much better. So I would like to thank you for staying here. Half an hour goes quick, and I'm happy to stay here if you have any discussions or any questions. Thank you.